My name is Ong Kee Leong, and essentially I'm an orthopedic surgeon. My subspecialty would be in sports orthopedic surgery, primarily the shoulder and the knees conditions. I graduated from medical school way back in 2001. Then after that, through further specialist training, another almost 8 to 10 years, and got my exit qualifications, specialist accreditation in 2011.
Wow.
Yeah, so it's quite a long, tedious.
Yeah, it sounds like a very long time between when you graduated and you finally got your...
Yes, because in between there's also the SAF, NS obligations also.
Right. There's also NS. Cool. I'm just curious, which hospital were you from when you started?
When we were training, as surgical trainees, we rotate around all the hospitals or most of the hospitals in Singapore. And once we have gotten our accreditation, then we settled down, and I settled down in Changi General Hospital.
Right, because I remember Changi is one of the few hospitals in Singapore that has a sports clinic as well, right?
Yes, they have. Yeah, they are, if I'm not wrong, the first one to have a Changi Sports Medicine Center.
All right, can you briefly describe to me, like, how do you typically see patients? And I guess today we'll just focus a bit more on the shoulder.
Yes.
Like, normally when they come in, how do they present? And can you just walk me through roughly what happens?
Right. Well, shoulder conditions are fairly common in my practice, and they typically present in two spectrums, the age spectrums. One are the elderly groups, as well as the more elderly group, as well as the other one, the younger patients. So younger patients, they usually present after accident or sports injury. A lot of times they complain of shoulder pain after overstretching or swinging their arms in a game, tennis, or doing their weight trainings. So then they'll come in with severe pain. Some of them come a bit early, which is good. You know, to get access, especially if it's very painful, they will come earlier. But there'll also be a fairly significant number of patients who will want to self-treat first, you know, take some medication, see a general practitioner first, you know. Some of them will also approach a traditional Chinese sensei and see whether something can be done first. So when I see them, typically they would have usually have undergone some form of self-medication, and that's where I come in because it's not getting better. Whereas the other group would be the older folks. The older folks tend to be a little bit more of a gradual onset, not such a acute onset after an injury typically. They will have complained usually of pain that lasts for quite a few weeks to a few months, and they would usually not have had any incident or injury per se. You know, no swinging of arm. They would be quite surprised. You know, and they'll be wondering. They'll be asking me, "Doc, I didn't injure myself. I'm not sure why I've been having this pain. It usually goes away, but this time around it's way different. You know, it's not going away. In fact, it's getting worse. I can't sleep at night. I can't sleep on that shoulder. I can only sleep flat, or I can only sleep on the other shoulder. It's disturbing me." Yeah.
Yeah. Now that you mention it, my dad was basically saying all those things to me, like just a couple of months ago.
Oh no.
Yeah, he was like, "Oh, my shoulder's stiff, like pain, I can barely lift it up. Look, I can barely lift it up. It's pain when I roll on it." Like everything that you mentioned, my dad actually just mentioned that to me as well. Yeah. Thankfully now it's gotten better. Because again, he didn't really have any injury. He is relatively active for his age.
Good.
So after he did some shoulder rotator cuff exercises, it actually got better.
Yes.
So I'm actually quite surprised that he actually recovered in like 1 to 2 months so quickly. But is that what you usually see as well? Be like, how would you decide someone should go for just conservative treatment like physiotherapy, or to go for something more serious like surgery?
So it's quite a big area you're asking about. So I'll try to distill it down a little bit. So usually, first and foremost, when they do come, I need to speak to them, you know, and find out a bit more about their condition, whether is it a very bad injury that started all this severe pain? Am I worried about a fracture or dislocation? Oftentimes, if let's say a patient had fallen down, significant impact, significant mechanism of injury, I would have asked him to consider at least getting a simple X-ray, just to make sure. A lot of times they will be in quite severe pain without the help of all these investigative aids. It's really quite difficult to sometimes tell, especially when the fracture may be just a mild, small fragment avulsion injury. So really depending on the mechanism of injury, if I'm worried, certainly an X-ray, right? But a lot of times they don't have a fall, right? And if they don't really have a bad fall, oftentimes it's not really a fracture that I'm worried about. I'm worried about soft tissue injuries. So soft tissue injuries such as, say, a rotator cuff strain injury or tendon inflammation, maybe a tear. Not every rotator cuff injury is a tear. It can just be impingement. It can be inflammation due to wear and tear, multiple repetitive movements. For example, if you're training hard, doing kettlebell, weight training, sometimes you overstrain, overstretch, mind over matter, trying to push in order to lose weight faster. We do see a lot of these kind of patients, and in the midst of trying to get stronger, get lighter, get faster, they actually do themselves a disservice and get injured. So that kind of soft tissue injuries, typically I would ask them to consider an MRI scan, especially more so if it's very symptomatic or it has been quite prolonged already. How prolonged is prolonged? Well, typically if it's 1 or 2 weeks and there's no real red flags, no bad falls, no open wounds, that kind of thing, then I can still offer them a chance to self-recover and give them a chance, to take anti-inflammatory medication, get them to see a physiotherapist, or if they don't really want to see a physiotherapist, then I'll just tell them and advise them how to move their arm, that they must certainly still want to move the arm, despite the pain. Try to help themselves by taking some anti-inflammation medicine or painkillers, any painkillers, even good old paracetamol, something, just so that they can kind of artificially, I usually tell them artificially depress the pain so that they can at least try to mobilize it. But of course, having said that, it must be something that has no reflex. You can't have a fracture and then ask them to take the medicine and just avoid the matter. So the reason why I say that is because a lot of unfortunate cases, they don't take the medicine or they don't see a doctor to get the medicine, so they just endure and they don't move the arm. So from a simpler strain, they can actually over time become more and more stiff, and that's where some of these patients unnecessarily becomes a problem of a frozen shoulder. So like for example, when you mentioned your dad, right, he's beginning to feel a bit of stiffness back then. It was a good thing that you brought him to see a physiotherapist so that he knows how to move it safely and properly, and that probably helps stave off any worsening of a frozen shoulder, which will be harder to treat later on. Yeah.
Wow. Okay. I think the biggest surprise for me is learning about that painkillers part, because from what I've seen with a lot of, or maybe the people that I interact, maybe a lot of older people that I know, they are very averse to painkillers. So it's good to hear that, hey, actually painkillers does serve its purpose. Again, if there is no red flags, there is nothing, if the mechanism of injury or if the way the person injured himself isn't too drastic, wasn't from a fall, then maybe taking painkillers and then going forward to just keep mobilizing it, maybe see a physio to get the joint moving, exercising it, training it can actually improve.
Yes, but don't wait too long, because sometimes it can be something else that's more sinister. So I would say if you are going down this route of no red flags, and you want to try taking medication and seeing whether that helps, maybe give yourself about 1 to 2 weeks at the very most. It should settle if it's something mild, but if it goes beyond that, I don't think it's wise to take that risk to continue. Right. I think you should get it seen at least by a general practitioner, a trusted family physician, a physiotherapist. Even the physiotherapist will be able to tell the patient, or at least have a good assessment whether or not this is something a little bit more serious than just a simple strain, which is more common. But sometimes you need someone who is more experienced in this to identify, or at least to say, hey, this is not exactly how it should be. You should at least get it checked.
Yeah, okay. So I think 1 to 2 weeks is a very good mark. If 2 weeks and it's not recovering, maybe even if it's getting worse, then that's when you should really seek professional help. Really look for someone that can help you diagnose.
Yes. In the end, it might be nothing at all. It's just that perhaps you are not putting enough time and effort into doing the exercise, or maybe you're not taking the medicine, right? Busy. A lot of people in Singapore, we're all very, very busy. priority is always like the last thing. You got to get the work done. Family comes first, children comes first. So then it gets relegated to the bottom. So sometimes it's just like that. So you have to prioritize yourself.
I will take note of that when you mentioned, like, mind over matter, just keep training. I think, I've done that quite a couple of times.
It's quite common, unfortunately.
Got my knees aching for that, my shoulders. It's always the knee and the shoulders for me. So I've overtrained those and was forced to take like a 6 weeks break after that. So I'm also trying to learn how to modulate. Hopefully it doesn't get any worse.
Yes.
Okay, so you mentioned that we should go see a physio. Sometimes we should see a physio and get it diagnosed. When should someone consider seeing a physio from your perspective?
Well, I think most simple strains and sprains, you can start off with seeing a physiotherapist if you are comfortable. First, you must be comfortable with the prospect of just seeing a physio. A lot of us, we have been trained since young, must see a doctor. Physiotherapists, they have the experience and they have the qualifications to identify most severe problems. It's quite clear to them. If let's say the shoulder is not moving, this is completely off. Maybe the patient fell, dislocated the shoulder. You may not know. You might just pass it off as just a simple strain, pain related, right? But when you see a physiotherapist, like for example Tim, right, when he sees the way you move, something is not right. He may even be able to see that there's a deformity of the shoulder region. So sometimes layman, we may not be able to identify that. They just say, it's just pain. It's just painful. That's why it's stiff. But sometimes clear cut right at the beginning, you can really identify this is not right. You're jammed. You're stuck, and you need to do something about it. And the first thing usually I would do if let's say the patient was to see me after seeing a physiotherapist, if that happens in that order, then an X-ray will be warranted because there's clearly a deformity. The deformity doesn't just come without any significant injuries, like a bony injury. So it could be a fracture, there could be a dislocation of the shoulder, it could still be out of the joint. If really clearly there's some bruising already seen on the shoulder, that oftentimes portends a fracture because the bone is bleeding. The fracture causes bleeding, so you see bleeding that comes down the arm. Can be quite significant sometimes, but if it's very early, it may be just a little bit of mild bruising, and you may not even pick it up because you may not even be able to see it from the back, right? So someone needs to have a look at it properly, front and back, all around.
All right, so let's say someone has shoulder pain and you have X-ray, he's actually fine, and then you say, hey, maybe physiotherapy will work for you, and then he goes all the way over, he finds Tim. So when he goes to a physiotherapist, can you roughly explain to me, like, what happens when, let's say, someone sees a doctor, X-ray done, we have cleared all the red flags, there is no fracture, there is nothing sinister going on, and he comes to you. Tim, what would you normally do at that point of time?
Right. So for physiotherapy, what we are more concerned about is actually function. So a lot of patients come to us because I can't do this, I can't do that. Yeah. So firstly, a patient that comes in like that makes my job much easier because all the red flags are cleared. I don't even have to, clear that anymore. I don't have to worry so much. But if a patient come in to me without any scans done or anything, usually the first thing I will rule out is red flags first. So usually if all those are ruled out, then I will be like, okay, so I will interview the patient as well. So what are some of the, things that you find that you're unable to do, or things that cause you pain, things that you're unhappy about. Some of them, I want to be able to lift, weights. I want to be able to at least carry my kid or things like that. But I find myself not being able to do so. So we'll set some goals. And then after that comes the assessment. So usually for physio, what we are concerned about mainly range and strength. These are the two things that will determine how good your function is. You need to be able to reach a certain range, have a certain strength, so that you don't have pain. So that is what I will be assessing, and then I'll tell the patient, these are the things that are lacking and what I can do for you. Sometimes I will also, most times actually, I will let them know the prognosis as well, because I think one of the things for physio working with patients is that it takes time. So patients they are quite concerned about the timeline. How long do I take to get better with conservative treatment as well? So usually this is the whole process of physiotherapy for patients with shoulder issues.
All right, so let's go through a scenario. Let's go through a scenario here where, let's say, Tom, someone in his mid-40s, he doesn't do a lot of training, but he got egged on by his best friend. So he went to High Rocks and he pushed really, really hard. He got a reasonable timing, but after that he had shoulder pain, very bad shoulder pain. He tried to rest for 2 to 3 weeks, but it's not really getting much better. It still hurts a lot.
Yes.
So let's say he comes in, knowing this background, what would you normally do?
Okay. So quite a common scenario, and typically what I would do when I see a patient like that is that I will find out all this history and then examine him, check the range, make sure that there's no deformities that could suggest a more significant injury. At the same time, also just to make sure that it's not from other sources. The pain can actually come from other areas such as the cervical spine. I always make a check just to make sure, because it can be a red herring. So after I've excluded that kind of pathologies, and it's all shoulder based on history and physical exam, I typically will order some investigations, and the investigations of choice for a shoulder injury that is looking more like a soft tissue injury would usually be a magnetic resonance imaging scan or MRI scan of the shoulder. This scan is actually about 30 minutes or so. You just lie down in there, but it can be a bit uncomfortable, but most patients don't have a problem. But most of the time they will tell me that it's a bit uncomfortable, which is fair. And the scan will usually tell me a few things. So for your example, Tom, 40 plus, who has been training for High Rocks, a common kind of result from the MRI scan would perhaps be what we call subacromial bursitis, impingement, a lot of inflammation, and maybe because he's in so much severe pain, perhaps he could show that he has a tear of the rotator cuff tendon. Typically not a big size, massive tear, especially if it's just happened, all right, and more acute in nature. I often see maybe a sub-centimeter, below 1 centimeter tear, which is not very big. Maybe a full thickness tear or a partial thickness tear, but not more than 1 centimeter. Very common scenario, but very, very painful because of the amount of inflammation that it has thrown out. And
could you just show me, since we have some models here, what is actually being torn?
Okay. So if you look at this is the shoulder. It's a right shoulder, and it's like that. Okay.
Oh, it's almost to scale too.
Yeah, it's almost to scale. And this is a clavicle, which is the collarbone. This guy over here, the prominent bone over here.
Right.
So the arm moves this way. All right, and in order for it to move this way up and down, all right, you have the help of the rotator cuff tendons. There are 4 of them. And the one that usually gets injured most of the time is this fellow over here, which is what we call the supraspinatus tendon. So what happens is that these 4 rotator cuff tendons, they all have their own function, and essentially they are like strings, puppet strings. And when the muscle contracts, because it's attached to the top of this arm bone over here, which I've just dislocated out, this tendon will then pull when the muscle contracts. This tendon attached here, it comes up. So it's like that. It comes up like that, right? Yeah. Now, most of the patients that come and they get injured on the rotator cuff tendon, they get injured on this fella, supraspinatus tendon, right? I would say in my practice, it's at least 90% of them are from here, okay? And what happens is that when this happens, there is a tear or rent over here. There's a gap. It can be a full thickness tear, which means that if I, for example, have a knife, let's say this is a knife, and let me turn it around like that. I think it's a little bit easier to explain. So a full thickness tear, a lot of patients ask me this question. They get kind of horrified when they see the MRI scan. Let's say they've done it somewhere else. Right. They say, oh no, it's a full thickness tear. Is it really bad? So typically, it can be a very, very bad full thickness tear where it is full thickness and full width tear of the rotator cuff tendon. That means if I stab it with a knife all the way through until it hits the bone on the other end, that's a full thickness penetration, right? Okay. But if it is a partial thickness, means I stab it halfway. It doesn't go right all the way through and through, so it doesn't touch bone on the other side. That's like a partial thickness. But an MRI result can call it a full thickness tear, and it can simply be just 2 millimeters or 3 millimeters in width, the tear. Whereas the rotator cuff tendon, the supraspinatus tendon width typically is between 10 to 12, maybe a bit more millimeters. So it's actually one small fraction of it. So don't be too worried sometimes. I do get patients that come and they're really panicking, full thickness, I need surgery. Sometimes they don't because, or at least I wouldn't propose surgery right at the get-go because it really is just maybe a 5 millimeter width, and it's just a fraction of the entire width. But yes, it might be full thickness all the way through and through, right? So this will cause a lot of pain. Even a small tear like that, if it is a tear, can cause a lot of pain. Even if there's no tear and it's just inflammation, which is tendonitis, it can cause a lot of pain because what happens is that there is this bone over here at the top, right here, like a roof, and that bone is called an acromion. And this acromion lies above the rotator cuff tendons. Sometimes the rotator cuff, sometimes the acromion is flat. It can be a bit curved. It can be very curved, or if in an older patient, sometimes there might be bone spurs that kind of protrude from juts out and downwards, like a little dagger. And when you bring the arm up, it kind of grates against it. It squeezes the space between the rotator cuff tendon that's injured against the bone. And that's when you get this impingement, severe pain. So when I see a patient like that, not too bad, less than 1 centimeter, if they say that, okay, I am in a lot of pain, I will certainly want to give him medication. Oral anti-inflammation medicine would be my choice. And I'll discuss with him the options, and I'll let him think about it. And in some cases, in most of the cases, if it's really a smallish tear like what I just described, I will usually encourage the patient to consider first a trial of conservative treatment. No harm done. You can try and see whether that helps. And a lot of them with such a small tear, they do get better, but it takes time. They have to be patient and they have to keep the faith in a way, and they have to still, unfortunately, have to take some anti-inflammation medicine. Most people don't like to take medicine, but the problem is that if they don't take the anti-inflammation medication or painkillers, they can't do the exercises that, for example, Tim is going to teach them. It's very hard to get going and it'll be a struggle. So as the doctor, I would normally try to make things easier for Tim also, so that encourage them to take the medicine temporarily. It's not permanently, right? It's just so they can get going, so that you can avoid other things down the road like frozen shoulder, now painful, and also a stiffening up shoulder, which is going to be a double whammy. Yeah. So that's when I was then, okay, why don't you consider seeing Tim first? I'm not saying that you may not need surgery later on, but surgery, as most everyone knows, there's always risk. I can't guarantee a full 100% risk-free surgery. So if it's not a very bad injury, like what I just described, can consider a short trial, maybe about 4 to 6 weeks, at least see how it goes. If it doesn't get better, then come back, we'll sort things out, we'll do other things. If it gets better, then great, fantastic, you have escaped. Because it doesn't mean that, and I do tell patients this, it doesn't mean that you get better after surgery, you cannot tear again, right? So you must just see whether you can get better first.
Yeah. All right, thanks. Yeah, I think that gives me a better understanding as well. And you mentioned that sometimes it's just a small tear, and that's why it kind of hurts. Now, I think the easiest way for me that help me visualize it is if you have a small cut here, even if it's just 1 cm, if I press it, it will still hurt. And so I'm guessing it's going to be very painful, even if you have a small cut here and you're pressing against it.
Especially if it's acute, it can be very, very painful. They can't even lift the arm up. Yeah, it really is very uncomfortable, and they can't sleep on it because when they have injury over here, they lie on it, they are compressing on it. So that's why they will have to avoid it a lot of times, and they will just lie flat or lie on the other side.
That makes sense. It's like pressing against a wound that you just got
on any part of your body.
Yes, and it's a lot of inflammation tissue that's going on that hurts.
All right, so let's say, like you mentioned, Tom only has a small partial tear of the rotator cuffs, the tendons, less than 1 cm. So he's handed over to Tim. So Tim, let's say you see a patient like that, or someone coming in with such condition. How would you treat the patient?
So firstly, I think if the patient coming with already the information presented to me, so I will do firstly an assessment, because sometimes they might be limited by the pain in terms of range and in terms of strength. So I will see what is the big issue for them, right? Not all patients with tear come in with a lot of pain, and not all patients with without tear come in with without pain as well. So one of the main things is that we want to see what is the main issue for them in terms of moving their shoulder first, right? So sometimes if let's say pain is the number one thing that is causing them to stop moving their shoulder. Firstly, I will see if they are taking any of their pain medications and things like that. Sometimes I will also nag at them as well. Like maybe you might want to take it before you come to physio so that I can actually do something with you, right? But fear not, even if you don't have, in the clinic we do have some pain relief modalities as well. Sometimes like ultrasound, therapy, TENS, something to at least help to distract you from the pain, right? So that we can actually do some exercise. Then after that, I will assess and see is strength an issue as well, and is the range an issue. So usually, if let's say strength is an issue, we'll give very targeted exercises to work on that strength itself. Most of the time in a pain-free manner as well. So if you don't know how to move your arm in a pain-free manner, actually that's my expertise. Just how to move it. At least you can if I can't move it this way, maybe I can slide up a wall. So give a bit more support. I can use my other hand to help me as well. At least that will be less painful. Then I get you to find ways to move it without pain first, right? And as your pain gets better, then sometimes I might say, okay, let's introduce some strength training into it, get the tendon much stronger. Because with a small tear, even with a small tear, and with a lot of pain, sometimes you can expect patients that they might either not have enough strength on the area already, or because of pain and because of lack of use, they might not want to exert. Yeah. But then once the pain and everything settles down, then I will start training on their strength. And then finally, after the proposed timeline, usually 4 to 6 weeks, then of course, I will get them to come in. I will see how they are functioning, and then of course I ask them a few questions. And if they are getting better, then good. If they are not getting better, then sometimes I will tell them, look, we have already tried conservative treatment and it's not getting any better. Then I will advise them to go back to see the orthopedic surgeon as well.
Right. Okay. So let's say it is someone like Tom. He has seen you. He's done a couple, maybe 6 weeks, and considering it's quite a small tear as well, maybe he recovered. Let's say. No, actually, let's go with what you mentioned. Let's say he did train, but it's not getting any better. Maybe he didn't do the exercises enough. Could be. Or maybe he went overboard. He tried to, after like 4 weeks, he's like, I'm healed. He ran out, he tried to do a bit more high rocks again. So didn't get any better, got a little bit worse. And so this time he comes back to you, Dr. Ong. So what would you do with this case?
Okay, so well, he has done about 6 weeks of physiotherapy. All right, he's been diligent because patients, if they go for physiotherapy, doesn't mean they actually do the physiotherapy on their own time, right? Sometimes they are very busy.
Who see a physiotherapist.
Yeah.
And then they're like, okay, I'll do the exercise when I'm at the physiotherapist.
Exactly.
Which is not enough.
Correct. So they are not miracle workers. The physios, they can teach, but you still have to do the work every day, on your own time. I would say usually about 2 to 3 times. If you can do twice a day, I think it's very, very good already. And needs to be consistent. So assuming he has done all that, Tom, and he's back and he has a recurrence of this pain, or maybe it didn't really get better even, then I will assess him independently again and see whether is it something new that has unfortunately happened during the last 6 weeks that I haven't seen him. If there is something, maybe a new fall or new injury, unfortunately, I may have to start from ground zero again and consider talking to him about another repeat MRI scan. Hopefully not. It's expensive, unfortunately, MRI scans. And what happens is that if it is not any new event that has occurred, it sounds like it's an old problem that is just not really going away. And after examining him, I'll talk to him about his options, right? Because we already know that he has a tear, a small tear, whether it's a partial tear maybe. Then I can tell him, okay, well, if you want to, you can try a bit more, see whether physio, it got you back one round before, you were better, that's why you going back to some sporting activities again, and you came back. So you can consider it, but there's a pretty decent chance that it's going to not really help because you already put in so much effort the first time round. So other options would be to just maybe don't do that particular sport. That's also an option, right? I mean, you can choose not to do that, do something else, pivot to something else, right? Or cross-train, maybe don't do so much of that particular activity, switch around a little bit. Sometimes you can play football, or instead of doing an upper limb intensive thing, go for jogs. Yeah, something like that. But if all that is done and dusted and it's really not working out, then options would probably be injections at this point of time. Can still offer it. There are some small risks that I have to normally tell patients if I'm going to offer an injection. An injection, usually what I'll do is an injection of steroids, cortisone injections into the subacromial space, which is that space that I mentioned earlier on, between the bone above the tendon, this space over here.
Right.
So, and the steroid injection typically will help to reduce the inflammation in a very directed manner, high concentrated steroids. It usually will help to bring it down a couple of notches, sometimes maybe even more than a couple of notches. Yeah. And typically I would still encourage them after the injection, go back, see Tim or the physiotherapist, or at least continue to work. Even if you don't want to see Tim, it's expensive also. Sometimes physiotherapists, it all starts to rack up, right? I mean, this is a fact of life. And just continue to do all your exercises, repeat. And if that works, great, because now we have addressed the problem, we have reduced the inflammation. But I will also tell him, depending on what the MRI scan shows, if let's say there is a significant curvature of that acromion roof bone, or maybe there is already a bone spur, or maybe there's a hardened ligament. There's also a ligament over here that I haven't mentioned called coracoacromial ligament. It can get kind of hard, and it kind of behaves a bit like a bone that is also protruding out because it's right at the same corner. Right. Then I'll tell you, it may not work, or it may be again the same old story where you inject, temporarily comes down, and then it comes back again once you go back. So in that kind of situation, then I'll offer him the option of surgery then. It's already tried already. I can't be asking the patient to keep doing this and repeat it. It's not working out, right? So I have to move on. So then surgery will be usually a keyhole surgery in my hands. It will be an arthroscopic procedure. And in most cases, it involves a decompression. That means a removal of that bone that is protruding, right? Just the bone that is protruding, the prominence, not the entire bone, because you still need that bone for other important muscles.
Like shaving it off a little bit.
Shaving it off, cleaning it out, thinning it out a little bit, create space in between the tendon and the bone, so that the patient can move better. And depending on what I see intraoperatively, the surgery itself will tell me whether or not that tear is the same small partial tear or has it gotten worse. So depending on the severity of it, if it's a mild tear, partial, sometimes you don't even need a repair. A decompression will suffice. However, if let's say unfortunately it has gotten worse, then I will need to repair it. This would involve usually suture anchors, some implants that is akin to stapling it back, that tendon back to the bone. Something like that. Yeah, I mean that's the easiest way to explain to patients without showing them the implants that I have, but it's typically just simply bringing that tendon that has torn back onto the bone. Because usually when there's a tear, the tendon will have kind of being separated from the bone. Yeah, and sometimes if it's very badly separated, it's been a long time, the muscle will start to waste away, and you realize that you are starting to get weaker. And these features are oftentimes seen on the MRI scan. You can actually tell that, hey, this muscle is a little bit more atrophic. There's some fatty infiltration. The fat has gone into the muscle. It's no longer as strong as before already. So that is really not good, because it's going to be even poorer later on. Yeah.
And that's when you would have to do surgery and just like get it all back.
Exactly. So after surgery is done, it typically will involve a period of time for the post-op rehab. Surgery is only, I normally tell patients 50%, as a guy, 50% of the surgery, 50% of the success of your condition treatment is in the surgery. But if you don't do the other 50%, it may even be worse now than before the surgery, because it will be painful and you don't put in the time and effort to do the therapy consistently. You can get stiff again, because pain will cause you to not move. Pain from the surgery now will cause you to not move, and if you don't move, you don't take the painkillers to help you to move, make it more efficient, then you get a frozen shoulder. And sometimes that happens if a patient doesn't want to listen. Yeah. Right. So I normally make a point to make sure that they take the anti-inflammation medicine just for this period of time to get you going, and then see a good physiotherapist so they can maximize your potential after that.
Yeah. Okay. So after all that, they'll see a good physiotherapist like Tim.
Yes.
And then they will probably do certain exercises as well. I'm guessing you've really kind of covered roughly how the physiotherapy would go for, but I'm curious as to how long this would take. Because just now you mentioned maybe 4 to 6 weeks. There's no operation done, it's just some exercises. But let's say they do go for some sort of surgery. How long do you think it would take? Is it going to be in days, weeks, months, or years?
Typically months for starters, but I would say that for physiotherapies, number one thing, especially if a patient comes through op, right? Actually, we take the post-op instructions from the surgeon themselves, like Dr. Ong. So I will ask him, what are some of the precautions I need to take? Because, to me, he's the expert who knows more about the shoulder that he repaired. So he knows what he did in the shoulder, right? And then he will tell me, what to do and what not to do. I think that's the most important thing when a patient comes through the door, the first thing after op.
Right, I guess you would know whether it's just a light shaving or if you had to staple back the tendon, right? I'm guessing that will also result in a different kind of
recovery time.
Just to clarify, we use the word staples just as a descriptive term, but it's usually not metallic nowadays. Some patients do ask these questions, when they realize that there will be some implants. Are these implants made of staples, or are these implants made of metal? Are they going to cause a problem when we travel? Things like that. So they are not metallic nowadays. In years long ago, we used metal implants, but now they are all surgical grade plastic. So they don't beep, they typically don't have a problem going through immigration and all that.
Not every time you go travel, it'll start beeping.
Yeah. So as to address the question about how long a physiotherapy is for typical rotator cuff tear repair, I normally would say it's about 6 months, but of course it's an estimate, but because the reason for that is that when we do a repair, we have to be very careful. We don't really want to have all the effort being done, repairing it, shaving off the bone, and then the patient is allowed to do a lot of things, and he accidentally pulls out the anchors. So normally we will have to immobilize the patient with an arm sling for about maybe 4 to 6 weeks typically. And but it doesn't mean that he's stuck with that arm sling. In my practice, I typically will allow them to start moving it, and I'll tell the therapist, I'll give instructions how much to move it. A relatively common rehab instruction is usually up to about 90 degrees, what we call passive range of motion. That means no energy to just yank it up like that, but from the other arm to gently bring it up so that you still move, so that's to reduce the risk of frozen shoulder coming in. Because if you completely just in the arm sling and don't move, then you're going to probably end up with a very stiff shoulder. So you still must move, but it's kind of a compromise. Move, but move very carefully. Right. Yeah, and there'll be a safety restriction zone.
Yeah, and that's where Tim comes in. You help the patient make sure he doesn't bring his arm all the way. Exactly. You guide the patient on how to actually slowly train up, so they can slowly start from maybe passively moving to active movement, and eventually get back to full range of motion. I guess that's the fingers crossed plan. All right, thank you so much for sharing. Okay, so to end off, so Dr. Ong, what are the 2 things that makes the biggest difference in the recovery time of someone post-op?
Okay, I think certainly a positive attitude. All right, that's very, very important. It will pass. The pains that they may have felt or they may be feeling immediate post-op, it will only get better. So a positive attitude is very, very important. And that, of course, will influence how the patient does the physiotherapy, turns out for their usual follow-up reviews, not being impatient. So it encompasses everything, positive attitude, right? You've done what you could, so now leave it to the professionals to help him or her. And at the same time, the second thing is to make sure you prioritize the rehabilitation. As I mentioned earlier on, a lot of times patients sometimes will deviate from the treatment plan. They might forget, they might get busy. Things get busier, maybe the MC is already over and done with, expired already, and they're back to work. And when you go back to work, it's different for the first 6 weeks or so, when you're well rested. Maybe you have taken the full 6 weeks of MC, perhaps some of them do that, but not always necessary. It really depends on your work, right? But a lot of times patients, they kind of do less physio. They have other distractions now. and then they don't prioritize it. I'm not saying that it must always be tip-top, number one. I mean, it's life, right? You have to go through work, you have to submit your assignments and stuff like that. But just make sure that you keep it going. By then, you should be much better. You don't have to be so military in that sense. You have to keep doing 3 times a day, that kind of thing. But you must still keep the consistency. Yeah, because you will be feeling better. And typically when we feel better, we kind of take shortcuts, right? So that cannot be the case. So I usually see them, and when I see them, typically in the clinic, there's really not much I can do. It's just mainly a rah-rah kind of a thing. I'll just encourage them, just make sure they're okay, that they're not falling astray, getting delayed here and there, whether they've been still taking their medication on and off. Sometimes you still have to take it even at 3 months, just so that you can, but not so regularly, of course, but you just have to take it so that you can push further. Because every time you see Tim or the physiotherapist, you're going to be doing usually newer and newer stuff, and he can't progress if, let's say, you don't satisfy the checklist of requirements before that. So all this is important, and that's why the consistency, the prioritizing, still has to be there. Unfortunately, it's a commitment. Surgery is a commitment, and not everyone can do surgery or wants to do surgery for that reason. So I do tell my patients upfront before the surgery that it's a commitment. You have to be disciplined. It's not like do already and then you're all going to be okay. The hard part comes later also. Yeah.
All right. So the 2 things: having a positive attitude, that's important.
Yeah.
And afterwards, making sure you follow through with the physio and all the post-op exercises as well.
Yeah.
All right. So Tim, what are 1 or 2 good habits someone should keep up in order to maintain a healthy shoulder?
Well, I think firstly, for healthy shoulders, mainly even a consistent type of workout regime or exercise plan, because oftentimes muscles fail, right? All these things happen because the things you do outweighs, the strength that is required, right, outweighs the strength that you have. So like let's say, with high rocks, you have to throw the ball 100 times, but can your muscle actually do it for 100 times? Actually, most of the thing I would say is conditioning. So if you are not prepared for that particular activity, it is quite common that the muscles might fail. But if you are prepared for it, right, you condition yourself before actually taking on a very intense activity, then I think that will actually keep the shoulder pretty healthy.
Right. So really conditioning and just continue to do your exercise, just like daily exercise or weekly exercises. And if you're doing anything specific, then you should train for that, condition your muscles for that. Exactly. Am I right? Yeah. Okay, cool. Thanks so much for both of you. Really enjoyed today's sharing.